Decimase stripping automated endothelial keratoplasty has become the gold standard for the treatment of corneal endothelial disease. As the surgical technique has progressed, the operation has become reproducible by corneal surgeons all over the world. The learning curve has flattened, and 20/20 visual acuity is now often rapidly achieved for patients with good visual potential. As DSAEK has developed, indications have expanded. Patients with endothelial failure and cataract now routinely undergo DSAEK combined with cataract surgery. DSAEK has been reported successful in eyes with anterior chamber IOLs, in eyes with iridocorneal endothelial syndrome, and in eyes with posterior polymorphous dystrophy, just to name a few. This, of course, is in addition to the more common indications being Fuchs endothelial dystrophy, pseudophakic bullous keratopathy, and failed penetrating keratoplasty. Patients with more complicated past ocular history may also benefit from DSAEK, in particular from the reduced intra- and post-operative complications and the rapid and improved uncorrected and corrected visual acuity. With the aid of this video, we propose that the indications for DSAEK have now spread beyond those even imagined in the very beginning. With appropriate modifications, phakic patients with clear lenses and normal accommodative function may stay phakic. Aphakic patients may avoid or delay secondary IOL implantation when appropriate. Patients with complicated past ocular history, such as this aphakic patient with failed PK and massive iris defect, or these patients with ophthalmos, may rapidly improve. Patients with severe corneal edema or even opaque cornea may avoid unnecessary penetrating keratoplasty. Phakic patients undergoing DSAEK run the risk of developing cataract, particularly as a result of intraocular trauma upon insertion of the graft, as seen in this patient with early development of anterior cortical cataract. Of the first 33 phakic patients undergoing DSAEK at our centre, 6 eyes developed traumatic cataract. In an attempt to reduce the intraocular trauma associated with insertion of the donor tissue, the incision sites were shifted, slightly superior to their usual 9 and 3 o'clock positions. In this way, pass of the intraocular instruments across the exposed and unprotected lens was avoided, and we hypothesized that the risk of cataract would be less. Whilst the risk has not reduced to 0, to date only 1 patient with the new wound position has developed traumatic cataract. Here, the instruments are passed across the eye, without risk to the underlying lens. Surgery can then proceed in the normal way. Absence of an appropriate diaphragm between the anterior and posterior segments may provide problems during DSAEK. This diaphragm may take the form of the lens, posterior capsule, or iris. However, absence of any of these may allow the donor tissue to sublux into the vitreous cavity. To avoid this problem, a transcorneal suture may be useful. For this technique, donor tissue is placed endothelial side down on viscoelastic. Both arms of a 10-0 Prolene suture are passed through the donor tissue, through the nasal corneal wound and out through the temporal cornea. Tissue can then either be folded or mounted on a preferred device and inserted. Once inserted, the suture may be tied off, providing a known point of attachment of the DSAEK lenticule in these cases with poor visibility. In eyes without an adequate diaphragm, complete air tamponade may be difficult. If interface fluid remains at the end of the case, detachment is likely. Full thickness corneal venting incisions, as described by Francis Price, are useful in these situations. DSAEK in cases with anterior chamber intraocular lens provides an interesting challenge, and the problems vary depending on the type of lens used. This table shows our initial cases of DSAEK in eyes with Kelman-type ACIOLs. The post-DSAEK endothelial cell loss was unacceptably high. In contrast, cases with iris claw ACIOLs seemed to do well. However, these eyes did result in other problems, such as post-operative disenclavation of the iris claw lens. For these reasons, any ACIOL thought to be unstable should be removed and replaced with a sutured PCIOL. The old lens is removed and the new posterior chamber IOL is sutured to the sclera. DSAEK may then proceed as normal. The main difficulty with DSAEK in the setting of previous glaucoma surgery, whether trabeculectomy or tube shunt surgery, is the maintenance of air in the anterior chamber. PK, however, is also more complicated in these patients, and DSAEK has become the safest and most effective option for treatment of the endothelial decompensation, as shown by these results from our centre. In this case, with a Multino drain in situ, the surgeon is experiencing difficulty in achieving an adequate airfill. Each time the needle is removed, the air disappears up the Multino tube. Here, the surgeon maintains constant pressure, leaving the 30-gauge needle on the air syringe inserted through the peripheral cornea, whilst he drains interface fluid with stab incisions using a 15-degree blade. In this way, attachment is achieved, with minimal excess manipulation. Ocular history for patients with buff thalamus is different in every case, and surgery must be tailored accordingly. Donor tissue of 9.5 to 10.5 mm is required, and an eccentric donor punch must be avoided. After the microkeratome cut, a manual excision of further peripheral anterior stroma is generally effective for these cases. These eyes and many more would have undergone PK or conservative management just 5 years ago. Today, following DSAEK, these patients have achieved rapid visual improvement and have been able to return to school, work, or their hobbies, with relatively less risk and complication. Indications for DSAEK surgery have extended beyond the horizon. We look forward to the many possibilities that lie ahead.